Hello everyone, this is part 2 lecture of the development of the digestive system. And I will start it with number of foregut developmental abnormalities. First to mention is the pyloric stenosis. This condition is characterized by hypertrophied circular and or the longitudinal musculature of the pyloric wall, causing extreme narrowing of the pyloric lumen, and the passage of the food is obstructed. This abnormality becomes visible between 2 and 12 weeks of development, with symptoms including projectile vomiting without any presence of bile in the vomited contents. Second to mention are the liver and gallbladder abnormalities, such as accessory hepatic duct and duplication of gallbladder. Both considered asymptomatic. However, they become clinically important under pathological conditions, and they must be surgically removed following laparoscopic cholecystectomy. In extrahepatic biliary atresia, the hepatic duct failed to recanalize. Cholestasis, or when the bile failed to flow, is complete and permanent in this condition. Thus, a liver transplantation is required in these conditions as an effective way of treatment. In pancreatic abnormalities, there is a condition called annular pancreas. This condition happens when the left ventral pancreatic bud migrate in opposite direction to the right ventral pancreatic bud. Thus, the duodenum is then surrounded by pancreatic tissue, and the annular pancreas is formed. Another condition is called accessory pancreatic tissue. It is rare, and this could occur when pancreatic tissues appear in other regions of the digestive system, such as the esophagus, the intestinal loop, the stomach, and in Meckel's diverticulum as well. In midgut, the primary intestinal loop, as shown in this picture here, is formed by rapid elongation of the gut tube and its mesenteries. The apex of the loop remains in open communication. The apex of the loop remains in open communication with the vitelline duct or the yolk sac. The cephalic portion of the loop forms the distal part of the duodenum, jejunum, and part of ileum, whereas the caudal portion of the loop forms the lower portion of ileum, cecum, ascending colon, and the proximal two-thirds of the transverse colon. At this stage, the abdominal cavity is still less developed to contain all the elongated loop inside the cavity. Thus, it temporarily enters or or herniate into the extraembryonic cavity, as shown in this picture. And usually it herniates in the umbilical cord area during the 6th week of development. The herniated loop returns to the abdominal cavity during 10th week of development due to the expansion of the abdominal cavity. The proximal portion of the jejunum is the first to re-enter and lie on the left side of the cavity. Later structures settle more and more to the right side. Cecal bud is the last to re-enter the cavity. Following retraction of the herniated tube or the herniated loop inside the abdominal cavity, the gut rotates counterclockwise 270 degrees around its blood supplier, the superior mesenteric artery. 90 degrees of those during the herniation itself, and the rest 180 degrees during the gut retraction to the abdominal wall. A mobile cecum is one of the abnormalities of the mesenteries. This is caused by persistence of the right mesocolon that fails to attach to the posterior abdominal wall. The cecum and the ascending colon becomes redundant and can move freely in the abdominal cavity. This condition found in 10 to 20% of the population. Usually it's more common in females than males. And in 2% they present as acute intestinal obstruction. In most extreme forms of the persistent mesocolon is a condition called erythrocolic hernia. Is the entrapment of a portion of the small intestine behind the mesocolon. Omphalocele is one of the defects that happen or occur in the abdominal body wall. And this condition involves herniation of abdominal viscera through an enlarged umbilical ring. The viscera, which may include liver, small and large intestine, small stomach, spleen, and gallbladder, are usually covered by a layer of amnion. The origin of the defect is failure of the bowel to return to the body cavity from its physiological herniation during 6th to 10th week of development. Omphalocele is usually associated with high mortality rate and severe malformations. That usually includes cardiac anomalies and neural tube defects, represent 50 and 40% respectively. Nearly 50% of live-born infants with omphaloceles have chromosomal abnormalities. In gastroschisis, is a herniation of the abdominal content through the body wall that goes directly into the amniotic cavity. It occurs lateral to the umbilical to the umbilicus, usually on the right side, through the region that is weakened by regression of the right umbilical vein, which normally disappears. The viscera here are not covered by a layer of peritoneum or the amnion, and the bowel may be damaged by the exposure to the amniotic fluid. Gastroschisis is less common than omphalocele in occurrence. However, gastroschisis is increasing in frequency, and this usually occurs among young women. This level of increase have been found to be correlated with using cocaine. Unlike omphalocele, gastroschisis is not associated with a chromosomal abnormality or other severe defects. Thus, the survival rate is excellent. Vitelline duct abnormalities occurs in 2 to 4% of people, as a small portion of the vitelline duct persists, forming an outpocketing of the ileum called the Michel's diverticulum or the ileal diverticulum. In the adult, this diverticulum is approximately 40 to 60 centimeters in length. It usually doesn't cause any symptoms. However, when it contains heterotopic pancreatic tissue or gastric mucosa, it may cause ulceration, bleeding, or even perforation. Sometimes both ends of the vitelline duct transform into a fibrous cords, and the middle portion forms a large cyst, an enterocystoma, or the vitelline cyst. Since the fibrous cords traverse the peritoneal cavity, intestinal loops may twist around the fibrous cords and becomes obstructed, causing strangulation or volvulus. In another variation, the vitelline duct remains patent over its entire length, forming a direct communication between the umbilicus and the intestinal tract. This abnormality is known as umbilical fistula or the vitelline fistula. A fecal discharge may then be found at the umbilicus. In gut rotation abnormalities, there is a condition wherein abnormal rotation of the intestinal loop may result in a twisting the intestinal loop or the volvulus formation, compromising blood supply to the gut. Here, rotation only amounts to 90 degrees, resulting in left-sided colon, as shown in this picture. Another condition is called reverse rotation of the intestinal loop. The primary loop in here rotates 90 degrees clockwise. Thus, the transverse colon passes behind the duodenum, shown here, and lies behind the superior mesenteric artery.